So next we move on to the next session, talk by Dr. Shabeeba. Okay, she is a consultant in Agarwal Eye Hospital, Calicut. She'll talk on the right patient, the selection, and what consent has to be taken.
Yes. Thank you, Soumya Madam and the KSOS for the opportunity. As a novice strabismologist, I would share some of my thoughts regarding the right patient selection and consent. As we know, the common indications for strabismus surgery are either functional or reconstructive. Coming to the functional, our aim to create a comfortable single binocular vision and to enlarge the field of binocular vision, to relieve diplopia and to relieve the mechanical restriction. Coming to the reconstructive part, our aim to establish normal facial configuration by aligning the eyes rather than purely cosmetic. Coming to the selection of patients, it mainly depends upon two factors. First one, our surgical skill and previous surgical exposure, and second one, where we are working. If we are working in a tertiary care center, we have lots of referral patients and we can choose convenient cases according to our skill, and also our seniors will be there to guide us. But as a single strabismologist, we don't that advantage. We hardly get a convenient case to do. And factors which consider while choosing the cases. In the initial cases, we have to choose best outcome cases because it will slowly build up our confidence, then we will take more complicated cases. Horizontal rectal surgeries are easy to do and the calculations are more predictable, so we can take on horizontal rectal surgery as initial surgeries like alternating exotropia, IXT with consistent PBCT values, and essential esotropia. And coming to the age of the patient, better to avoid initial surgery on infants because of anesthesia risk and also the strabismus measurement errors. And it is ideal to choose an adult patient with constant exotropia with amblyopia in that eye at the initial career. And the patient should be highly motivated, like those who want surgery before the marriage or before an interview, but plan surgery well in advance of their due dates of function. And don't take up confusing or complicated cases initially. And in our OPD, we have more complicated cases also, like children with any neurological disorders. In that case, there is chances of variable outcomes post-operatively, complex strabismus, second surgery, adult strabismus with diplopia, and variable strabismus. In that case, we have to keep that cases under follow-up if possible. And if we are confident enough to do that, then we can take on up later. And thorough preoperative evaluation is must in all cases before touching the patient or taking into the operation theatre. Repeat measurement of the strabismus at least 2 to 3 times between a gap of 2 to 4 weeks. And if a patient presented with esotropia, we have to rule out the accommodative component with proper cycloplegic refraction. And we have to give the classes according to the refraction, and again we have to check before taking the patient in case of partially accommodative esotropia. And in case of intermittent exotropia, we have to do patch test to rule out any pseudo-divergence. And if a patient presented with acute strabismus, usually we plan in that case surgery after 6 months only. And before taking the case for the surgery, we have to do imaging to rule out any neurological causes and rule out any patterns or vertical strabismus associated with the horizontal deviation. And counseling is an important part. We have to clearly explain about the chances of success, and chances of reoperation is there about 5 to 10%, and chances of postoperative diplopia, and clearly explain that there is no effect on the visual status postoperatively, and the surgery is not the end for that treatment. Glasses or patching have to be continued to maintain the clarity of vision. And informed consent should be in the local language, a clear explanation of the rehabilitative nature of the strabismus surgery, educating the patients regarding intended benefits of improved and maintained stereo acuity, mainly in children, and as well as improving the ocular alignment, that is cosmetic purpose in adult patients. Discussing the appropriate expectation is key with patients who have diplopia, because it is important to explain the goal of increasing the field of single binocular vision rather than eliminating the diplopia in other cases. In addition, it is important to discuss that there may be change in the extraocular muscle function over time after the intervention. which could require an update of the level of prism in glasses or a second surgery. In all cases, we have to talk about the anesthesia risk also. As a novice strabismologist, this is my first case. This is a highly motivated 13-year-old girl with intermittent exotropia. After thorough orthoptic evaluation and ophthalmic evaluation, her best corrected visual acuity was 6/6 vision in both eyes with a mild, that is 0.5 cylinder in the right eye. I have done 3 PBCT measurements, and 2 before the surgery and 1 on the day of surgery, and her PBCT was constant. It was about 40 base in right eye for near and distant, and there is no pattern. I have done lateral rectus recession with a medial rectus application. And postoperatively, patient has only mild exophoria with no diplopia, and patient is happy postoperatively. And take-home message for today, we should take highly motivated patients, and the PBCT value should be consistent before the surgery. Choose a horizontal rectal surgery as first few cases, initial career, and pros and cons of surgery should be clearly explained in the local language. Thank you.
Thank you, Shabeeba, for the wonderful talk. And I would like to say she was one of the best fellows in our Contrast Hospital. And all the best for your future endeavors.